Kia ora, Dr. Moxham. Any problems with the patient today?
Kia ora, no, none at all.
Excellent. You may begin.
Thank you. So thank you so much for asking me to see angina today. Anne is a 64-year-old Pākehā woman who presents at a crisis point in her healthcare journey with a new diagnosis of ischemic heart disease and dealing with some long-held health anxieties, health beliefs and avoidance of healthcare. There are 5 main issues in Anne's history today that I'd like to discuss, and those are ischemic heart disease, chronic kidney disease, hypertension, ex-smoker and asthma. The first issue I'd like to discuss for Anne is that of ischemic heart disease. This first became an issue for Anne about 2 years ago when she developed some exertional chest pain while working on her lifestyle block. She delayed presenting to the GP for a number of months because of some fear around what might be found out when she presented for assessment, but she eventually presented for workup, was referred into hospital and underwent a CTCA scan, which confirmed that she had some evidence of coronary artery disease, and she was scheduled for an outpatient angiogram, invasive angiogram. Unfortunately, while she was waiting for this invasive angiogram, she presented acutely with myocardial infarction, which I believe from the history is an NSTEMI, but I'd like to corroborate that with her records, in July of this year. She had 2 stents placed acutely, and she had an echocardiogram during this hospital stay, but she's unsure of the results of this. In terms of risk factors for ischemic heart disease for Anne, the key ones for her are a long diagnosis of hypertension, which has been poorly controlled previously, a family history of ischemic heart disease at a young age, and being an ex-smoker. As far as I could tell from my history with Anne, she doesn't have diabetes and she doesn't have dyslipidemia. In fact, she reported that she had good lipid levels. In terms of her treatment that she's undergone for ischemic heart disease, she's had 2 drug-eluting stents placed, and she's on 2 antiplatelet agents, aspirin 100 milligrams once a day and ticagrelor 90 milligrams twice a day. She's on atorvastatin 80 milligrams once a day and bisoprolol 1.25 milligrams once a day. She's also on candesartan 32 milligrams once a day, and she's unsure whether this is the antihypertensive that she was previously prescribed or if it was started in her recent hospital admission. She's also prescribed GTN spray, but she's never had to take that before. The second issue I'd like to discuss for her is the long-standing diagnosis of hypertension. So she was diagnosed at age 34 with hypertension after her second pregnancy, in which she either had gestational hypertension or preeclampsia. She's not sure which of those. To her knowledge, she's always been asymptomatic of her hypertension, and she's been on a variety of different medications previously, including multiple medications at one time, but has had a lot of difficulty in remembering to take those medications, and now she believes her blood pressure is well controlled on the single agent of candesartan. She tells me when she was younger and first diagnosed that she had some investigations into secondary causes of hypertension, including a scan of her kidneys, but she's unsure what the other investigations were. She's never had any side effects from being on antihypertensives that she's aware of, such as postural hypotension, and as I mentioned, she's previously had a lot of difficulty with remembering to take her antihypertensives, but since her heart attack has had a lot more motivation in terms of being compliant with her medications, or adherent, with her medications, and is taking them regularly now. The third issue for Anne, and what she actually puts as her most important issue in her healthcare, is that of a diagnosis of chronic kidney disease. She's unsure of the severity of her chronic kidney disease, and this was told to her during her recent admission with a myocardial infarction. It was diagnosed on a blood test, and as I said, she's unsure of both how long it has been going on and how severe the chronic kidney disease is. She is very concerned about the chronic kidney disease because she had a brother who had glomerulonephritis and then went on to have renal failure and dialysis at a reasonably young age, which markedly affected his quality of life and his length of life, as he ended up dying of complications of dialysis. As far as she's aware, she's not on any specific treatments for her chronic kidney disease and doesn't have any specific advice in terms of treatment of her chronic kidney disease except for staying well hydrated. The current management plan is just monitoring of her renal function through a blood test, which she understands is going to be managed by the GP. She doesn't think she's ever seen a renal physician for her chronic kidney disease. The fourth issue I'd like to discuss for her is that of asthma, which is a relatively quiescent issue for her now. This was diagnosed in early childhood, and she doesn't remember the diagnosis, but had quite severe asthma exacerbations as a child, precipitating multiple hospital admissions, but she doesn't think she ever went to ICU. She was on some preventative medication, but she's not sure what as a child, and now she just has PRN salbutamol, which she thinks she uses less than once a month. She doesn't have any hay fever or eczema. The relevance of her asthma to her current presentation is that before she started developing exertional chest pain, she had some exertional dyspnea, which she put down to asthma, but with retrospect, since it has improved post-stent, she wonders if actually there was an element of ischemic heart disease then. Also, in the context of her being a previous smoker, I think that it's important to keep in mind the alternative diagnosis or the development of chronic obstructive pulmonary disease. She isn't aware of any investigations for this and seems to be relatively asymptomatic without frequent chest infections, sputum production, and now post-stenting, not much exertional dyspnea either. In terms of Anne's kind of mental state around her health, she's had huge issues previously with health anxiety and avoidance of healthcare, particularly after watching her brother suffer on dialysis. She felt that not knowing was better than knowing, and that medical interventions would actually make her quality of life worse. She has managed to stay relatively optimistic throughout her recent hospital admission, and describes herself as a person with a get-on-with-it attitude, and has found this to be a protective factor going through this healthcare journey that she's been on recently. In terms of insight into her medical conditions, I think this is also something that's changed radically since she was hospitalised earlier this year. She says herself that she was previously in denial about having any medical issues at all, and I think that ongoing education and involvement in collaborative decision making with her will be really important. In terms of her medication, I've gone through them during her past medical history. In terms of compliance or adherence with her medication, her daughter has purchased her a dosette box, which has improved her ability to take medications greatly, and she thinks she's missed less than one dose of her medications in the last month. In terms of she has no allergies or adverse reactions to drugs. In terms of family history, I did mention that she has a family history of early ischemic heart disease, and her father had a myocardial infarction in his early 50s, and as a result of that, heart failure with reduced ejection fraction, which he eventually passed away from. Her brother also had a myocardial infarction before he passed away while he was on dialysis, but she's not sure how old he was at the time, but he passed away in his mid-60s. No other relevant family history for Anne. In terms of her social history, she lives rurally with her husband on a lifestyle block, and she's very active at home. She's a retired teacher. She's independent with all her ADLs, and previously did have some limitations to her exertion with her chest pain and shortness of breath, but this has been much improved post-stent, and now she spends the majority of the day outside being physically active. She previously worked as a teacher and states that she hated it and is much happier post-retirement, and feels that her life is a lot less stressful than it previously was. She still drives, and most of her hobbies are based around spending time with her husband on their lifestyle block and doing gardening and caring for the small amount of livestock that they have. In terms of future planning and future health planning, she does have an enduring power of attorney, which she appointed during her recent hospital stay, and that's her husband, Mike. She doesn't have a will, and she doesn't have an advanced care plan, but she has faith that Mike understands what her wishes would be and would like to defer to him with future decision making if she was unable to make decisions. She is a previous smoker and smoked about a pack a day for many years, starting in her late teenage years and quitting about 5 years ago. She drinks no alcohol and never has, and she doesn't use any other recreational drugs or over-the-counter medications. In terms of her relationship with her GP, she previously had a really poor relationship with her GP. She avoided them and said that she felt that they were nagging her to come in for regular investigations. She's really interestingly still with the same GP, but finds them a great source of support post-hospitalisation, and feels that ongoing she can trust them and will go to them regularly. In terms of cancer screening, she's up to date with breast cancer screening, and this year has had flu and COVID vaccines. On examination today, Anne appeared generally well. She appeared older than her stated age and was a slim Pākehā woman. She had a blood pressure of 142/82, which she states is a little bit higher than usual, with a heart rate of 69 beats per minute and a rest rate of 18 per minute. In terms of her cardiovascular exam today, she appeared euvolemic with a JVP of about 2 centimetres above the sternal angle, dual heart sounds with nil added sounds, and her apex beat was not displaced. She didn't have any peripheral edema in her sacrum or her legs. Her chest was clear to auscultation without any creps or crackles, and she had normal expansion and she didn't appear overexpanded at rest. She had good peripheral pulses in terms of her peripheral vascular state, and the other exams findings were not contributory to her exam. So in terms of the 5 problems that I'd like to discuss for Anne today, I think the first and most important one is the management of her recent diagnosis of her ischemic heart disease, although Anne didn't state this to be her most important issue. I think the second one is her chronic kidney disease in terms of investigations and ongoing management, particularly as Anne identified this as being her most important health concern. And the third is around her previous health anxieties and healthcare avoidance and how we can work to create a collaborative relationship with her going forwards. Fourth is risk factor management for ischemic heart disease and further myocardial infarctions or cardiovascular disease. And the fifth is around advanced care planning.
Okay, thank you for that very thorough history. I think, yes, let's start with your first problem and tell me more about how you would manage her ischemic heart disease.
Yeah, so I think in the first instance, so she's had 2 recent stents, and I think this is really important both in terms of medical management and education for her. So her being on dual antiplatelet therapy for a year was something that she was aware of, and that one of these would stop after 1 year, and I think that that's really good that she's got that knowledge around the importance of being on antiplatelet therapy. I think that educating her around symptoms of ischemia is really important, as she hadn't previously recognised that shortness of breath could represent, particularly as she's an older woman, ischemic heart disease, and so that would be something that I'd want to look into.
So just tell me a little bit about that. It sounds like you think so some patients are going to present atypically with their ischemia. So you can tell me a bit more about that?
Particularly diabetic patients, which she is not, but older patients and female patients sometimes present differently with ischemic heart disease. They might just present with nausea and vomiting. They might present with dyspnea rather than the classic central crushing chest pain, and I think there's a lot less education in the wider public around those symptoms of ischemic heart disease.
Pretty important for us in the hospital, isn't it, if you think about women, elderly, diabetic.
They're everywhere.
Could almost say that's a form of gender bias, couldn't you, Dr. Moxham? But I digress. Please continue.
The other, I think, key thing for her would be for myself to review her echocardiogram. She reported to me that she thought it was normal, but I'd particularly be interested in whether she had regional wall motion abnormalities and what her ejection fraction is, and whether we need to kind of go forward with heart failure management, even though she appeared euvolemic and is asymptomatic at the moment.
In terms of if there were regional wall abnormalities, how would that change your management, do you think?
Well, I guess in terms of the effect that the myocardial infarction had on her heart function, she'd be more at risk of developing heart failure in the future. And it's also something that I would want to do serial echocardiograms on to ensure that if in the future she had regional wall motion abnormalities, that she might have some untreated ischemic heart disease. But I would expect those to improve with time post-MI as well.
And if she's got a reduced ejection fraction, which I probably suspect she does, how would that change your management?
Yes. So you'd be kind of like looking at the 4 pillars of heart failure management, and then in addition to that, education for Anne as well. So she's already on a beta blocker and a RAS inhibitor, which is candesartan. The other 2 would be spironolactone, which I think probably wouldn't be indicated at this point, given that she's got chronic kidney disease, which is also a risk factor for hyperkalemia, and she doesn't appear fluid overloaded. And then the other one, like in New Zealand, probably, well, depending on her echo results, probably wouldn't meet criteria for Entresto or empagliflozin, but I think those would be things to keep in the back of my mind.
And what would be the criteria around those? Would you need to be diabetic, for example, or just more severe in terms of your symptoms?
So from memory, but I'd want to check the latest guidelines for empagliflozin, she would need to be diabetic, but I understand there's some change in terms of qualifying for that just from an ischemic heart disease or heart failure point of view. For Entresto, I believe it's an ejection fraction cutoff and also taking into account ethnicity. So she's not a Māori or Pacific Islander, so that wouldn't lower her threshold for being able to be prescribed it.
So I think clearly you know a lot about ischemic heart disease. So let's move on and perhaps tell me a little bit more about her chronic kidney disease and how you might explore and manage that.
So I think apart from managing her anxiety around it and education around it, I really would like to review the investigations that she's had into it, because I don't have a great idea of the severity or the type of chronic kidney disease that she has. So in the first instance, I'd want to know what her creatinine and EGFR were and how they had tracked a long time. So she did say that she didn't used to get blood tests even when they were requested for her, but I'd like to know whether this is a sudden change with the myocardial infarction or if it's something that's been going on for a while. And then the severity, so looking at the creatinine and classing her into CKD 1 to 5.
Okay.
If she had, so she does have some risk factors for chronic kidney disease anyway that could explain if she had like CKD maybe 2 or 3. I'd be surprised if she had CKD 5 with just hypertension as a contributing factor, and I think that would prompt me to look further into possible causes of her chronic kidney disease and whether those could be better managed rather than just managing her hypertension.
Do you think her smoking may have contributed?
Yeah, absolutely.
Okay.
So she's got macrovascular disease in her heart, which has been contributed to by her smoking. She certainly could have microvascular disease in her kidneys as well.
What's the role of imaging in chronic kidney disease if you were, say, meeting her for the first time?
Yeah, so my understanding is that it plays a role, although it often ends up being non-contributory in this kind of setting. In terms of causes of chronic kidney disease, certainly obstruction is a cause, and that can only be ruled out on imaging. And so whether she had some hydronephrosis or something like that, that would be important to rule out. And then my understanding is also you can assess the kidneys themselves, their size, their symmetry, to understand like the chronicity of the kidney disease as well.
Okay. And let's imagine you're a trainee intern, just hypothetically speaking, for no particular reason. What would be your approach to a new diagnosis of renal impairment? How do you break down your differential diagnosis? What's your sort of framework for looking at that?
In terms of looking at the cause of the
looking at the causes,
So I guess you think about things before the kidney, including blood supply to the kidney, and things like dehydration or insults, and then you look at and that would include things like hypertension, and then looking at the kidney itself. Could she have had glomerulonephritis? Could she have another disease that's affecting the kidney? And then post-renal or after the kidney, if she had obstruction, possibly more common in men, for example, with prostate disease, that's causing kind of back pressure on the kidneys, and then renal impairment in that way. Excellent.
And if you were, again, to go from first principles using that framework, what would be your sort of first line basic investigations that you would want?
So in terms of blood tests, renal function, looking at electrolytes,
So and you'd do a urine protein creatinine ratio.
Urine protein creatinine ratio, particularly if they were presenting acutely, looking at things like inflammatory markers as well. Whether the urine is like active or bland, as they say, nephrotic syndrome, nephritic syndrome. Yeah.
And given that she's clearly worried about the possibility of progressing to dialysis and using avoidance as a perhaps not very constructive approach to that, what do you think? At what point in somebody's renal impairment would you be referring them to a renal physician wondering about dialysis?
Yeah, so I guess if they didn't have a reason to be under a renal physician anyway, so if they had, like in her case, she's got plenty of risk factors for chronic kidney disease, and if it was mild, I think that would probably be within what we would expect for someone. So if they weren't previously under them for glomerulonephritis or something like that, then my understanding is that referral in kind of late stage CKD 3 or CKD 4 is the time to start thinking about dialysis and doing some advanced care planning. And I think there's particular value in having those discussions when people aren't at the juncture of needing dialysis, so that they've got time to process the information, the options available to them, and make kind of more of a measured decision.
Great. So I'm going to draw this to a close, because that's an excellent discussion of ischemic heart disease and chronic kidney disease for our trainee interns who are watching. So thank you very much. And Dr. Moxham is also post-night shift, so she's done a fabulous job here, team. And I am just going to ask you to perhaps speak to the camera and maybe give the trainee interns a couple of tips for the long case. For example, you could show them, you do a bit of show and tell for this.
Yeah.
Is there a tip that you would use with regard to that?
So I didn't use this as a student, but I've used this in my RACP exams, and it's a really common, I think, way of remembering. I don't know, are you allowed to take notes in your...
Yes, definitely allowed to take notes.
So having some structure before you go in, because I often find I get overwhelmed or like kind of carried away in the conversation, and you want it to seem natural and develop rapport, so it might not stick exactly to your pre-prescribed, but if you've got all of the boxes written down, then you've got opportunity to fill them in and remember what you've forgotten. So this part might be more kind of focused on the RACP exam, but the intro and summary statement. So I didn't do a summary statement for Anne because her introductory statement was pretty similar, but usually an overview, so you get an idea of who the person is kind of as a person and what their key medical issues are and what the key issues are kind of surrounding their healthcare that might not be as medical. So for her, ischemic heart disease, and I thought that her healthcare anxiety was going to play a big role in how I treated her and how also she interacted with the healthcare system. And then we go through and do like all of their past medical history as different points, try and think about when they first had symptoms, how they were diagnosed, what investigations and treatments they've had, and what they understand of their insight and prognosis of the disease. And then I really like doing a separate section for their mental health, including like insight, mood, I actually didn't mention for her, but goals for her life as well, so that you get a better understanding of what their understanding of their disease is, and you can work with them to achieve whatever you want. So for her, she did not want any dialysis in the future, and I think that might change how you approached her chronic kidney disease. And then really detailed social history. You can get so much information by just asking questions that you forget to ask when you're just doing alcohol, smoking, and allergies? ADLs,
yeah.
So like, what is their home like? Who do they live with? Who's actually supporting them through this? Where do they live? Do they live rurally? Is it going to be hard for her to come in for dialysis if she was going to have that, for example? I think you can get a good idea of what people are like functionally. They might be independent with their ADLs, but if they're still driving and looking after sheep, that's quite different from their daughter delivering their shopping and them rarely leaving the house.
Yeah.
And then I think particularly for older people, but surprisingly for younger people as well, not just have you thought about advanced care planning, but do you actually have an EPOA? Do you have a will? And what is your relationship like with your GP? What does your primary care look like, and what does it going to look like after you leave hospital? Medications, and then also are they actually taking the medications, because if they're not, it's kind of irrelevant what they're on. And then an examination, which can be like really important and contributory, or sometimes can be essentially normal and not really change your thinking too much other than ruling out things like decompensated heart failure, but going through the relevant body systems particularly. So for her, for example, actually an eye exam might have been relevant because she had hypertension, but it's kind of a bit different for different people. And then I haven't done this as well here, but identifying kind of 5 key problems and then going through them in kind of a stepwise way, like what investigations would you either want to review or organise, what are your next steps, and then what would your future management plan be.
So really helpful, isn't it, to have everything sort of pre-structured, so that when you're feeling overwhelmed by information and exam stress and sitting next to scary consultants, is that you've got places to write, you know where everything is, and you can just follow your plan and your framework.
Yeah, and you might not even use it, like these were my 5, but you might have really wanted to talk about advanced care planning, which I've written down as an issue, but at least then if there's a pause, you've got stuff to talk about and you've got stuff that you think is important that you want to say.
Excellent. Thank you, Dr. Moxham. I'll let you go home.
Thank you.